There are important clinical differences between patients in their pathophysiology and their responses to treatment. How to rationally apply therapies based on the specific needs of an individual patient?
Thank you for the question. So one of the problems, of course, is that the brain isn't like any other organ. And the brain is much more complex, just in normal physiology. And then when the brain is injured, the pathophysiology is just so much more complicated than any other organ. And it has to be complicated, of course, because that's why we are. That's why we're intelligent, that's why we can think, that's why the brain controls the whole of the body. But it does mean that when the brain is injured, it's enormously complicated. And the difficulty has been that historically, we've largely focused on just intracranial pressure monitoring, so how swollen the brain is and how high the pressure is. And if you think about it, that's a very blunt measure of these enormously complicated processes that are giving rise to the intracranial pressure. Biochemical processes and physiological processes and sometimes physical processes as well. So just to think about it in terms of what the pressure is inside the brain seems an incredibly blunt tool. So there are two major problems with that. One is that it's not addressing the underlying problem. So you're treating the consequences of a problem rather than the problem itself. And all the strategies that we have to treat the pressure inside the brain has potential harmful effects on the brain or the rest of the body. And so sometimes one has to accept that it's a balance between the benefits and the risks. But you have to be sure that there's enough benefit that offsets the risk. And you also have to be sure that you're treating the underlying problem that gives rise to the intracranial pressure rather than just treating the intracranial pressure. So to enable one to do that, one has to get more information. And it can't just be about intracranial pressure. But that's where it becomes difficult, because there are only a few centers in the world that have developed significant experience with the other forms of monitoring the brain. And the difficulty is added to because the more information that you get, the more you are aware of actually how complicated brain pathophysiology is. But then the hope is that you're at least trying to make sensible decisions based on what's happening to an individual patient, not averages. So the truth is, and we're learning this increasingly in medicine, not just in traumatic brain injury, but other forms of medicine like cancer as well, that you can't treat everybody the same because they all have slightly different problems or different manifestations of the problem, and therefore they need different treatments. Treatments that are targeted to their problem, not the consequence of it. So the way we use monitoring is to try to get as much information as possible, try to understand what is happening physiologically in the individual patient, and then making the best decision for that particular pathophysiology in that particular patient. And also it may change from day to day. So it may be true for now, but 6 hours later the situation is different. So we have to adapt our strategy. And traumatic brain injury is this incredibly dynamic evolution over time. It's never one thing. But that, of course, means that we have to improve our systems. And our systems are well due for improvement.
What are the indications from the Seattle International Severe Traumatic Brain Injury Consensus Conference?
So thank you for the question. So that meeting was a unique meeting in that it attempted to address something that current guidelines have failed to address. And current guidelines have often focused on the evidence that we have for strategies to treat traumatic brain injury, which is a great concept. The problem has been that the evidence base hasn't been there. Because again, the brain is so complex to do big randomized controlled trials that account for all the complexity of subgroups. It's just incredibly difficult, so we don't have those trials. And therefore we don't have the evidence. And so the guidelines reflect that lack of evidence. But people read guidelines not just to look for evidence, they look for guidance. They want some guidance and direction in difficult circumstances. So they don't just want to read about the evidence, they want experts to be able to say, this is the evidence that we have, and this is the evidence that we don't have. And in the lack of evidence, these are the things that we would recommend you do because these are the things that we agree on. Now, whenever you're trying to develop that kind of consensus, you need to be sure that you get a broad enough opinion, because every center does things a little bit differently. We live in this incredibly distributed world: Europe, North America, South America, Africa, Asia, Australasia. Everybody does things a little bit differently. So the great thing about the Seattle meeting, it brought a whole bunch of experts from different disciplines: surgery, emergency medicine, intensive care, from different regions of the world, literally from every continent. And we worked through documents for several months and then met with each other to thrash it out, and then came up with a set of recommendations that we could all agree on, and also identify the things that we couldn't agree on, and publish that into a document that then became a very practical recommendation. And as I understand it, despite it being published quite recently, it's been downloaded so many times that reflect its usefulness to a reading public.